record. Awesome. Thank you all so much for being here today and indulging in that question for today. I thought it would be nice and lighthearted to just think of ourselves as like plants growing flowers. I love peace lilies and I wish I could have one, but I have cats and they're toxic to cats. So one day I'll get like a really high shelf and put it on there. But thank you all for being here today. Our first Zero Suicide Learning Collaborative of 2025. We have Dr. Laura Walsh presenting today. And so I'll go ahead and introduce her in this space and transition over to her. So Dr. Laura Walsh is a clinical psychologist, widow, and stepmother. After losing her wife to a psychosis-induced suicide, Laura embarked on a path to make sense of it all in hopes of providing comfort to her boys, the family, and the wider world. Widowhood is a singular experience. No one knows the inside of a marriage except the two people in it. Thus, no one experiences the loss and accompanying experience is the same. Laura found no clear intersection of the elements. Her wife was a Chicago police detective where stress and PTSD run rampant. As a lesbian wife, there were no resources that spoke to her experiences. Typically considered the end of the depression road, her wife's suicide was fueled by delusions and psychosis instead. Her road to understanding the events, both clinically and personally, has led her here. And so today she is going to present on addressing non-disclosure of suicidal ideation in emergency mental health care settings. So without further ado, I'll pass it over to Dr. Walsh.
Thanks everybody for being here. It means a lot and I appreciate it. I'm going to see if I can share my screen. Um, uh, uh, uh. It was just there and now it's gone.
Should be in more. It always disappears there.
Yeah, it was just there and now it's,
So you'll see the little hexagon with end, and then right next to that is more.
Hey, Chris,
you're,
how's
you're
it going?
assuming let me start it in PowerPoint. Hang on. I don't know. I'm so sorry. I had
Okay,
practiced all this and then now.
let me see. I can go ahead and share the screen.
Oh, I
Got
found
it?
it.
Sweet.
I got
Awesome.
it. Okay. Can everybody see it?
Yes.
All right. Now it went away. All right. Are you seeing my presentation notes?
No presentation notes, just the presentation itself.
Got it. Okay. All right. So I'm going to be talking about addressing non-disclosure of suicidal ideation in emergency healthcare. I'm a clinical psychologist. I'm a private practice. I'm a writer. My current project is writing for my own publication called Reframed. And like I was introduced, I'm a suicide loss survivor. So it's um, an important topic to me. So we're going to talk about, um, all the things that come with non-disclosure in mental health and emergency mental health care and what we can do about it. We've got some learning objectives and, oh, did it go away? Can you still see it?
We see the presenter notes, I think, or just the whole, there we go.
Okay, sorry. I'm actually an introvert and this makes me really nervous. So
All good.
thanks for
This is a
bearing with
good space. We're with you.
me. Okay, so we're going to talk about recognizing the challenges of non-disclosure and incorporating collateral information. And does everybody know what collateral information is? I assume you do, but it's it's information from family, it's the context, it's providers that had referred the person to the ED, that sort of thing. And then we're going to talk about like what kind of tools can we use to build trust and utilize effective things that are going on that apply specifically to the non-disclosure aspect. Okay, so first I want to talk about what do we mean by non-disclosure? And, most of us are in some kind of like clinical or administrative role or something like that. And when we look at non-disclosure, we think of it as, something maybe that the person is withholding from us, or, um, uh, an issue that we have to address. And I want to try to get you into the shoes of the individual. Now, I also know that some of us here have lost somebody to suicide. And so I want to be mindful of that and, take appropriate self-care in the exercise I'm going to lead you through. So I want you to get into the shoes of an individual who's showing up to the ED. And we want to look at what it's like from the inside. So you're in a bad spot mentally, and you find yourself at the emergency department. How does this feel? What are you seeing around you when you get there? You're on a gurney. There's all this activity going around with you. They want to put, the monitor on your finger for O2. They want to take your blood pressure. People are coming in and out of the room. Um, how does it feel to be half naked with like this oversized shirt that's open at the back? You're hooked up to monitors. Um, you're pelted by questions, right? Everybody's busy, they're official looking, and you're having to explain why you're there. They're asking you, right? And maybe you don't even know. You might be really confused, you might be really overwhelmed. So among all those medical questions that somebody asks you, a stranger flat out asks you if you're feeling suicidal. And maybe you felt suicidal on and off. Maybe you wouldn't even call your thoughts suicidal. Maybe, you've had suicidal thoughts, but you don't think anybody can do anything about it. And maybe you actually have a plan to end your life and you don't want anybody to get in the way. So, how much detail do you go into, sitting there on the gurney with this stranger asking you questions in a space that isn't exactly private? So, we call this from the outside non-disclosure, but it's not withholding information from the individual side. It's so much more complex, and most of the time is not a deliberate action. So this is Patty, my wife. I'm going to use her as a case study because I have so much information about her. She's 51 years old when she took her life and left me and the boys. And she's I have this information, but she's just one person that slipped through the cracks. So the information I'm going to tell you is widely applicable. Plus, I'll also add that she would have wanted me to use her as an example to teach people. She and I used to talk about suicide and police officers and things like that. So I believe I would have her permission. So I'm going to tell you just the bare information that she presented with at the ED. And I want you to start thinking about like, what questions you would have, what signs would you have dug deeper in, and like why things got missed. So, and I'm going to talk about it in third person. Hope that's not weird. So the patient is brought in by ambulance after her wife calls 911 to report a mental health crisis. The wife tells the operator that the patient is a police officer, and the operator asks if her firearm is secured. The wife says it's in the patient's safe. The call is coded as acute behavioral on the paperwork by the EMTs who give that to the hospital. So patient, she's agitated, but she's alert and lucid. She's able to answer the nurse's intake questions, and her primary complaint is a severe headache with some secondary arm numbness and some mild pain in her left eye. Side note, so there's another in this emergency department, there's another mental health crisis going on because we can hear somebody like yelling, and getting kind of not in a way of like they're having a complaint, but it's evident that it's another mental health crisis. And the patient, she's slim, she's petite. The only medication she takes is a short-acting Adderall for ADHD, and she hasn't taken it that day. She has no significant mental health history. Though she's in the process of seeking treatment for this sort of arthritis-like pain, she doesn't have a diagnosis yet. The patient eschews all medication. She won't even take an ibuprofen for the pain she's been feeling. And she doesn't drink, she doesn't use illicit drugs, and she is opioid naive because her mom has a history of pill addiction. So all of this is charted. All of this is told to the nurse and charted. So the wife is present, pulls the nurse aside, and the wife tells her that she's a clinical psychologist and that her wife is experiencing significant paranoia and increasing delusions. This is charted too. She also adds that the patient was sent home from work because of bizarre behavior. So the patient's bombarded with questions. She's sitting on the gurney, she's got the robe on, and she seems somewhat oriented to person, place, and time, but she doesn't know the exact date. She's asked 2 questions from the Columbia suicide screener, and she denies depression and suicidal ideation. She just kind of blows it off. She says she's just been extremely stressed working on a high-profile case at work. This is all charted. She's angry with her wife for disclosing the paranoid delusions. So she gets a CT, comes back normal, and she's given 4 milligrams of morphine. Within a half an hour, she's calmer, her symptoms have subsided, and she's still alert and lucid. So the wife pulls another nurse aside and says she cannot take her wife home like this. The nurse says she'll tell the resident, right? So the resident comes in, they talk, and he says he's going to bring in his attending. So they wait, and finally the attending shows up, and he's just kind of like, okay, you're ready to be discharged, and gets her ready and says, the only thing you're going to do is, you had a potassium deficiency, so we're going to give you a potassium pill before we let you go. So then the patient is unceremoniously discharged and they go home. So what stands out to you? I'm trying to look at the chat to see if anybody notices anything. Are there any signs that you see, as a result of this? Yep. Yep. Yeah. So no mental health eval. They weren't listening to the collateral information. She had paranoid delusions. Morphine. Yeah. Why morphine? Right. I actually asked for a mental health consult on there, and they said it's really hard to get a mental health consult in the ED. That's what they said. So there was some, issues with the particular people that we were working with. I don't think that this is a, something that happens with all EDs. No safety planning, no follow-up. Why so much morphine, right? She's opioid naive. It doesn't make any sense. Also, she gets the 4 milligrams of morphine and she's not sleepy. You would think that she'd be sleepy, you know? They also, I don't know if people know this, so this is in Chicago, and she's a Chicago police officer. And first responders have a higher rate of suicide anyway. And the CPD rate is estimated to be 60% higher than the regular first responder rate. They have a major problem. So this is something that's just in the air there. And all these risk factors that are going on. Now, so we know now that she was experiencing a first episode psychosis, and that's a rare event. And someone her age, just, we don't expect it. 51 years old, we don't expect it. We expect it in late teens, 20s, and with women, sometimes it has a recurrence in the early 40s, but 51 years old, no mental health history. We don't expect it. So a typical urban ED sees maybe like 100,000 people a year, and like about 15% of that is psychiatric, and of that, about only 1% is maybe involving psychosis. And I'm estimating, I know there's probably people here that have much better numbers than me. So just wanted to give you a picture of that. So we know emergency departments, they're a busy place. There's a pressure to turn over beds. The likelihood of it being anything, I'm coming back. The likelihood of it being anything other than a headache is pretty slim. So how do you catch the risk of something so uncommon, so unlikely? She might not even have been suicidal at that moment, but psychosis presents, a greater risk of suicide, especially after a first episode. So what's our responsibility? Sometimes I think about the role of statistics, and I think they give us this false sense of security. Statistics, you know, they're predicting the likelihood of something happening, but outliers exist. So we know that certain risk factors increase the risk for suicide, but what does that even mean? Like, how do we use that in a practical way? If somebody presents and they have a really high risk, but they're not feeling it, they're not feeling suicidal. We just know that it could turn into that. How do we deal with that? So we're going to take into account that it's not feasible to do a full mental health assessment on every person in the emergency department, right? But are there easier ways to flag certain information? Can we create a safer and more comfortable experience that allows, individuals to reveal the private information? So it's a rare event. You know, many more people report suicidal ideation than actually attempt or take their own life. And so it's a statistically safe strategy for emergency departments to operate efficiently in regards to suicide screening. But it's leading to some missing keys, and maybe we can do something better without increasing the workload on doctors, staff, nurses, that kind of thing. So I have some easy ways I want to think about, like, what increases risk. So if you think about life history, if you can ask questions about life history and get some information, about like adverse childhood events, abuse, therapy, how much processing they've done, that's great. But you're probably not going to be able to get that much information. But I just want, just got to think about it. Then we think about like current stresses, so everyday life stressors. People who have a lot of stress, it's taking a little bit of their coping ability, a little bit of their resources in order to be able to function. So we want to know kind of like, what are the current stresses going on? But then we want to look at antecedents. So what happened in their life just prior to coming to the ED? And the key is saliency. Like, so what is, something that's happened that's salient to the individual? It might be that the person assessing says, oh, your dog ran away and came back. That doesn't mean anything, right? But if it's salient to that individual, then that intensity is what matters. So I think of it in terms of catalysts and calamities. So catalyst is like a tipping point. It's like the straw that breaks the camel's back. It's usually some kind of ongoing chronic condition or stress, and it's mounted to become distress. And it could be a change in psychiatric medications. It could be a long fight with depression. That's what happened with Kate Spade. It could be chronic pain or like eye dryness, tinnitus, skin conditions. All of those are have increased risk factors for suicide. So think of the catalyst as like the tipping point or the straw that breaks the camel's back, and that could be what's bringing that person in. It's harder to see, but there's there. And then there's calamities. So calamities, big life events, right? It floods the person's ability to cope. They're somewhat easier to spot because you can point to it. It's a new thing. And it could be a recent loss, a divorce, or a death. It could be a big medical diagnosis, like what happened with Robin Williams. He was diagnosed with Lewy body dementia. And it could be the brink of financial ruin, like a person's about to lose the house, but they didn't tell their spouse. Legal charges, losing your job, marital rift. You kind of get the picture, right? A big event that's just happened. Put substance abuse in there and everything is escalated, right? Because people kind of get at the end of the rope. And that's kind of what we're looking to see. All right, so what are some of the barriers? Seems obvious, right? If you just look at this, of course. But I want you to slip into the shoes of the patient again. You're in the whirlwind of that emergency department and you're feeling just awful. You're just feeling awful. Maybe you're like, I just want to get out of here. And you don't think anybody can do anything to help, because nobody else has ever, right? So what fear are you going to have to not say something, right? Stigma, right? Maybe it feels weak to say something about how you're feeling. You might feel like you're going to be judged or somebody's going to respond to you with pity. fear of consequences. So specifically with Patty as a police officer, she was thinking about maybe how it would affect her job. Maybe they take her gun, they put her on psychiatric leave. And the rumor mill in Chicago is crazy. So she was maybe thinking like, no, it's not bad enough for that. Then there's distrust of providers. It's really hard to establish rapport quickly and in a sort of busy thing. But I wonder, is there some way we can establish a balance between efficiency and connection? So that's something we'll talk about. Then lack of insight. So even though somebody might be at a high risk of suicide, and we know this, we know like these things kind of add up, they're not feeling it. They don't relate to it. So I think of it almost like a risk of a heart attack. We know that there's all these risk factors that go into somebody being, on the verge of having a heart attack, but they're not necessarily feeling sick. So that's kind of how I talk about it. Additionally, somebody might not realize the lethality of their thoughts. So for instance, if you think about frequency, duration and intensity of thoughts, because suicidal thoughts are fleeting, right? But if they're slowly starting to increase in frequency, duration, and intensity, that's something that's kind of going on. Then you add in anything having to do with psychosis, and the patient becomes an unreliable narrator of their life. So that's why we need to, involve collateral. Okay, so provider blind spots. We have to account for major outliers. Obviously, Patty was experiencing a psychosis, but there's no follow-up note explaining her symptom. There's no treatment plan that accounts for it. So if you're putting it in the note, you've got to take care of it, right? So how do maybe there's better systems for flagging something that's like a big deal. Like you wouldn't flag necessarily a tummy ache going with a headache. That makes sense. But psychosis, that's something bigger, along with a lot of other things that just might be strange. Missed opportunities. How do we make sure this key information gets to providers? The 911 call was coded as behavioral, but somehow it got lost in transition with the hospital. And we also want to be able to foster a safe environment for people so we can have open communication, right? That's another missed opportunity. Collateral, obviously, I'm, passionate about this particular piece, but collateral information could be potentially pure gold, right? You're getting very little information about this patient, and then you have somebody who can maybe provide some context, and that can help you with like your differential diagnosis, you're just getting a better picture of that. Of course, you have to address things with confidentiality, HIPAA, getting consent, and then there's barriers that the particular family member or friend might have to overcome. They might be scared they're telling on their friend, or there might be some kind of reprisal that could come from, disclosing something from their spouse, especially if there's, abuse involved in the relationship. So we've got to be careful about that. So I want to give you something that you can kind of hold in your head, right? So we've got the calamities and catalysts. So what happened right before, salient distress. So what actually matters to this person that you're seeing, and then collateral info, like what kind of context can you bring in? So it's kind of like it's something that you have to be able to pull from, not some kind of thing that you look at to do the assessment, because that's going to be just one more barrier to, getting a good assessment. Okay, so we want to encourage open communication. So one of the big things that the research is saying is a provider's confidence and knowledge. And I think this goes along with anybody who's doing an assessment for suicide. So proper training is great, right? But a comfort level in asking questions, because sometimes people fear like, oh, what happens if that person says yes? What do I do then, right? But you also need to know, what do you do if somebody does say yes, if somebody does share this with you? And especially if you don't have like a clinical training background where you know how to hold that kind of stuff and you know kind of the steps to take, it can be pretty overwhelming. And I imagine a lot of physicians don't have the clinical part to it, or nurses or whatever. So if the provider is comfortable and calm, they're going to provide a better space for the person. We want to build trust. So sometimes that means you have to slow what you're how you're speaking, change your tone. You want to say, hey, I'm here listening to you. I really want to know the answer to your question. Non-judgmental. And if we can do something where the provider can sort of focus attention on the patient to sort of convey that, and maybe even clear the room if needed. We don't want to add too much of a burden on things, but there's something else we could do. Then there's cultural competence. So addressing the importance of cultural sensitivity and addressing distrust and fear with your person. That happens with like rural adults sometimes, or don't go to the doctor or something. Or if somebody has historically had problems with the healthcare industry or something, like, we just got to be careful that might be something that's happening. And then normalizing disclosure. We don't want to normalize that like suicide is okay. Like, that's not where we're going, but that people do talk about it, and you can discuss, you can frame things in a casual kind of way, normalize scenarios that you can draw from that say like, yeah, sometimes people, they go through this hard thing and it gets really hard and they start to think that suicide maybe is an option. Is that ever happened with you? That sort of thing. Then we want to enhance the environment. So of course, privacy and comfort. So if you can create like a bubble around you and the patient, and address maybe something that that they're worried about, like the implications of disclosure, and then assure them that you can work together to come up with a plan that works for both of you. And we'll talk about, there's a specific thing that you might already know about, but working together, like when I talk to people in my private practice, I'm saying, if you tell me that you have suicidal or homicidal feelings, I value our relationship first. We're going to work together to figure out, what do you need? What kind of level of care do you need that's going to work best for you? Then there's staff training. So there's a lot of myths around suicide, as I'm sure you're aware, right? That the person's attention seeking, or they're being a problem or something, or now we have to like keep this bed open for this person, right? So talking to staff, even if they're not the ones doing the assessment, to address bias, and just how they're going to interact with this person. There's lots of studies about nursing and bias, and one more person coming in, who has a great life and wants to kill themselves, that kind of thing. All right. I know we're covering a lot of stuff. We'll go through. I have lots of answers to any questions you have. I can't see the chat right now because I don't want to mess up our screen, but I will go back and look and see what's going on. So we need maybe more effective screening tools. So one of the things to think about is that screening tools, they rely on disclosure, right? So that's why the Columbia, it's used in EDs all over the place. It has lots of great efficacy research behind it, right? But if you have somebody who's not going to disclose, it doesn't mean anything. She just, obviously she was in distress, Patty, but she just blew off the questions, and that was it. And that was a missed opportunity, right? So we want to look at some different things. What I think is really interesting is there's this idea of prefer not to disclose. Thomas Joyner did a study on this. And so if you ask a question of, have you been having thoughts of suicide? And you have yes, no, prefer not to disclose. That answer, prefer not to disclose, actually is associated with a higher risk for suicide. It's almost like they're giving you a little peek. And so we have to pay attention to something like that. Also, I don't know if you've had experience with this, but when you ask somebody something on a written thing versus a face-to-face interaction, they are more likely to tell you the truth of what's going on with them, because they don't have to face your reaction to it. And so it's kind of interesting There's another study that showed that if you, on a written thing, if somebody endorses a higher level of external locus of control, so they feel like the world is acting upon them and they don't feel like they have control, and maybe that's what they perceive, right? Or they don't have knowledge of what will happen if they do disclose. But that marker of, the world is acting upon me, especially in that moment, is a higher risk factor. It's like a little hint. And then finally about written assessment stuff, um, missing data in a self-assessment, it's not a random occurrence. It likely points to some level of elevated risk. They didn't want to answer for some reason. And that actually points to follow-up after the care. So maybe you can't do anything in that moment, you discharge them, but follow up. And that's actually really important with people who are coming in and disclosing suicidal ideation, is the follow-up part. Okay, so some of you may have gone through CAMS care training or know about it, but it's fantastic. It's collaborative assessment. So the clinician and the patient are working together to understand what's going on, to understand the factors that are driving the suicidal ideation. They use a tool, there's like research, evidence-based tools to both assess the symptoms and how to deal with each of them when they're out, right? So it's treating suicidality as a symptom, which I think is accurate. I know there's debate around that. Comes up with a treatment plan, and it focuses on that person's unique needs. And it gives them a sense of empowerment, right? Like, oh, I have this thing going on for me. It's kind of outside of me. I am not suicide. I am feeling suicidal. And so it helps them engage in the therapeutic process better. But in the ED, another one is the Ask Suicide Screening Questions Toolkit. It's a whole toolkit. And it's brief, it's straightforward. It's 4 questions, designed for medical settings like emergency departments, and it's shown to identify risk even in people who are unwilling to disclose. Non-intrusive phrasing, that's kind of the way that they go. And I think that's how you get at things. If you ask somebody straight on something, that they can just say no, right? If you're asking around the question, sometimes you get more information. So it can also be used in like high volume healthcare settings, which I thought was pretty cool. So then we get into technology. And this is actually a really exciting thing. Now, it could be that, your department can't afford something like this. I get it. I think it's coming. I think it's going to be, more accessible going forward. But it's using all these different studies and all these different risk factors and kind of coming up with an algorithm to say, what's this person's level of risk right now? Even if they can't say it, even if they don't know it, so one of the things that might be a barrier to that is if the person doesn't relate to what's going on and they can't get past the stigma of, what suicidal is. They can't see it as a symptom. So that's a greater cultural thing we got to work on. But a couple of the mental health apps, there's Ellie AI, it's ELLIE.ai. Ellie Mental Health Assistant. So it uses natural language processing and voice analysis to detect distress during conversations. Right now, it's mostly in research settings and it's in pilot, but it's noted for being able to detect risk factors without necessarily asking. There's Woebot, WOEBOT. I think it needs a better name. But it's a conversational chatbot for mental health support. The crisis text line. Another thing to think about is if a person doesn't know if they're questioning whether the person's suicidal, but they're not quite sure, you can always call the 988 number and ask and try to get some advice. Same goes for family members. That it's not just a crisis line for the suicidal person to call and get help. So they have a lot of great information. But then there's other ones like MindStrong. It's a continuous monitoring thing. Cognito Companion, Bark, that's for younger people. It monitors children and teen activity. It's a little Big Brother-ish. But then there's the S scale. It's an AI augmented Columbia Suicide Severity Rating Scale, which is kind of interesting. There's one for vets, Reach Vet. So you kind of get the idea. There's now ethical considerations with that, privacy, algorithmic bias, that sort of thing. And it's just something to kind of get you in the better ballpark of something. So, all right, references. I got references out the wazoo here. And then thank you. I appreciate it. Appreciate you listening, paying attention. Are you back to my face now? And let's see, what questions do we have?
Thank you. We have one question. Please type or come off mute if you do have a question yourself. And then I think you're still sharing your screen.
All
Let's
right.
see. I can't do it. There we go.
Is it done? Is it
Yep.
still sharing?
Nope, you're good.
Okay.
Awesome. From January, is there a list of these AI digital resources?
I don't know of a particular list someplace. I did the research, but I can put together a list and
Awesome.
send it.
Yeah, we can send it in the follow-up email to everyone. So for this.
If you haven't been CAMS Care trained, I highly recommend it. The first training is like an hour. You get one CEU, and it's for everybody. It's not just for clinicians.
And then Kaylee from OSP oversees that CAMS training. So she dropped in a link in there for folks to get on the interest list.
Brief cognitive behavioral therapy. Um, we're starting to get into maybe like treatment of suicidality, and I don't know that I would. I don't want to go too far outside of my scope here, but I think using cognitive behavioral therapy, using motivational interviewing, a lot of times can be good for assessing somebody. And specifically with that, it could be like, okay, you're saying this, and then you're telling me this. Help me reconcile what's going on between those two. I hope this was helpful. I know that, you know, it's kind of like with police officers, we load a whole bunch of extra stuff on them. We try to have them be, mental health care and all this kind of stuff. I think the same thing happens with emergency departments. We try to load all this stuff on the providers there, the staff there, and you can't do everything, right? But, is there something that we can add in or some sort of culture change maybe that will help people? I mean, there's so much research that says if you're able to decrease bias and stigma, you might catch like 17% more people in their disclosing. For hospitals, is there capacity for mental health? Yeah, of course, mental health people can do that. And ideally, you would have that person at the particular hospital that Patty went to. They have a whole inpatient department. But, can you spare that person to come to the ED for maybe even a couple of hours, right? To try to assess this person. It's this big balance. If we had all the money in the world, of course, everybody would get properly assessed.
Eric, I see you raised your hand.
Hi,
Yeah.
Laura. Thanks again. That was actually very informative, and I appreciate it. I signed up for the CAMS training. I'm a peer, and I've done work in the ER. My thought is, how do you feel about including peers as professionals within the ER to supplement clinicians?
I mean, I think that's awesome. I think if we could train the whole world to become comfortable with asking questions, to become comfortable with saying the word suicide and it's not like cancer, I think that's great. Because there's so much suffering that goes on that's unaddressed. Why not try to train everybody on how to talk about it, right? Especially if it's a smaller ER or ED that of course we want to include peers. I want you to feel comfortable, especially if you don't have clinical training on like how to handle it, how to process it out afterwards so you can let go of it. But yeah, I'm all about the peers.
And then we have a question from Melissa. I can read it for you so you can like digest it. Can you provided the specific research that points to the response of prefer not to answer carrying higher risk? We have built into our ED workflows to auto-refer this population of patients to behavioral health for a risk assessment. However, we sometimes receive pushback on the why.
Yeah, it's in one of the references on the slide. And it's, I don't know if I can pull it up without messing up my screen, but it's one of the references. I believe it's Thomas Joyner that talked about it. It's an interesting study. It's interesting that because the prefer not to disclose has even a greater risk of suicide than somebody saying yes, that they have suicidal ideation. So, and for those of you that don't know, Thomas Joyner is the president of the American Association of Sociology. He's been doing research for forever. He's got some really interesting pieces to contribute to understanding suicide, and the theories behind why it happens and what to do about it. So, but David Jobs is CAMS, and he's also pretty amazing. I think he's addressing a very specific part of the whole picture, which is, once somebody discloses, then what do we do? Yeah. So
Another, oh, do you want me to read it?
sure. Yeah, that'd be great.
Okay, cool. So for Michael, I think ED providers and staff get callous to people because they see people at their worst, most manipulative, etc. Have you found ways to help ED staff to look past biases or cynicism when people come in with mental health and or substance use issues?
Well, I mean, there's training on it that people can do, but I think part of the reason why I wanted to present, like, put yourself in the patient's shoes, is because if we can understand something, like, everything makes sense if you can get to the understanding underneath it all of why somebody's behaving that way. And if you can see things from their eyes, um, and see what's motivating their behavior, that's the basis of empathy. But I think the callousness comes also from, um, for some people, taking it personally, like this person is personally troubling you, or wasting resources or something like that. And I personally think everybody, deserves help, deserves empathy. So that's also a shift in culture.
Thank you. Next question from Laura. Which is the best verbal and example, not written tools for nurses and MAs, not sure what MA stands for, who are hesitant to talk about suicide?
I mean, I would go with CAMS care, because it normalizes it. It's like this warm, welcoming community of how to talk about it. Yeah. And so it's kind of the same thing with that we were talking about with peers, right? For people that don't have that greater clinical training, they still need to have, the people training to be able to see past, bias and get comfortable with it. It's also the experience of just talking about it and saying the word suicide. For the longest time, I always thought I was traumatizing somebody else if I said the word suicide. But now it's like I feel like it's my grassroots effort to destigmatize by just saying it and saying, like, you can talk to me about it, it's okay.
Yeah, oftentimes when I talk about the Office of Suicide Prevention, just naming that, you can see kind of people really then like honing in and like paying attention to you. So I think just saying the word suicide too, right, opens up conversation and just like, okay, we can talk about this.
Well, and I have this theory that culturally we have an obsession with suicide,
Mm,
because, like, I think there's 20,000 murders in a year, and that's what gets put on the news, but there's more like 40 or 50,000 suicides a year in the United States. And so we don't talk about it because we don't know how to talk about it. We don't want to offend somebody. We don't want to open up a can of worms, kind of thing. But it comes out in our language everywhere. So, like, when people say political suicide, or suicide is a thread in a book or a podcast or something like that, or what drives me crazy is those Netflix shows that would be like, is it murder, suicide, or, and it's like, okay, well, when you sensationalize it like that, it makes it, you know, um, provocative, a topic to talk about.
yeah. We have a comment from Sarah. QPR is also good for one-on-one training and it's for non-clinical and clinical. So yeah, OSP also offers all of this on our training website, different opportunities just as a little tidbit there.
One thing that I think I want to stress is I think because we have this moralizing history of how we think about suicide and we think about people that do it or they're selfish and all that kind of stuff. I want to try to change it to be like suicide is something that happens to the person. Like suicidal ideation happens to the person. They're not thinking like, how can I, most people are not thinking, how can I stir up everything by being suicidal now? Right? That's a whole other category. But a suicidal crisis is happening to the person. And so if we think about that, they're not choosing it. They're not, you know, they have very little choice when they get to that point of like unbearable pain or, exit. And if we can try to understand that it's an event that happened to somebody, I think maybe that can help shift how we talk about it just more generally.
Awesome. Any other questions? Again, you can come off mute, drop it in the chat. No, looks like there's no more questions. If you do have any other questions or want to reach out, we will send out all that information after once the recording is up and all of that on the website. So, Dr. Walsh, just want to share, thank you so much for sharing your story, and then for giving us very practical tools to do the work that we all do here. So, thank you so much. And
Yeah,
thank you all for attending. Again, if you haven't dropped your name or organization, please do so I can count your attendance. But with that, hope everybody has a great weekend.
great. Thank you.
Awesome. I'm going to hang out just a little bit so I can capture all of the attendance. But again, thank you so much. I'll follow up with you via email and all of that. I'll attach your slides to our webpage for this presentation. So yeah, and then any other resources that you want to share as well, I can drop that in too.
Perfect. All right.
Awesome. Thank you so much.
Thank you.
Bye.